welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and MS specialist, and my mission is to engage, educate, and empower those affected by MS to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things MS, health and wellness, advocacy, and we'll even throw a little bit of music and music therapy in there as well. Thank you so much for joining us, and stay tuned for the next episode. Welcome to Brain Chat, friends. Happy Monday. It's Dr. Mitzi, the nerdy neurologist, and I am so excited to start a new year and a new season with you guys on Brain Chat. I can't believe it's season 3, and we have got some amazing guests and amazing conversations headed up this year. I hope that everyone enjoyed a restful and wonderful holiday. And you know how we do on Brain Chat. Drop in the chat where you are logging in from. I bid you greetings from the ATL, where we are so confused with this weather. We don't know what is going on. So 1 minute is 70 and the next minute it's 20, and heck, we don't know what to wear. But a very beautiful day here, and I hope that everybody's having a great day. All right, so let's talk about MS 101. So at the beginning of the year, I love to do an MS 101, which is great education, not only for people who are newly diagnosed, but for people who've had MS for a while. You know, you never be surprised how much you learn from hearing similar information, and also what you learn from other people, when somebody says it differently. So I am going to go ahead and introduce my amazing super friends and guests tonight. First, we have Dr. Jacqueline Rosenthal. She's a neurologist and fellowship-trained multiple sclerosis specialist at the Andrew C. Carlos MS Institute at Shepherd Center here in Atlanta, Georgia. She graduated from Morehouse School of Medicine, my alma mater, MSM, and she completed her neurology residency at Madigan Army Medical Center. Once she finished residency, she actually went to practice in general neurology and developed a special interest in MS and had the courage to go back to school and do a fellowship. God bless you, because I said I'm not going back to school after this. But she went back and did a fellowship and had a focus in her research on neurodegenerative biomarkers of cognitive dysfunction in multiple sclerosis. She joined the Shepherd Center's staff in 2019. She does clinical research, education, and spends time with her hubby and 2 boys. And then I'm also very excited to have Dr. Drake Macarthur with me tonight. He is a neuroradiologist, so he'll be our first neuroradiologist on Brain Chat. So we're going to learn a lot about the brain and those MRIs tonight. All those questions you ask, get those questions teed up. So he actually completed a BS in mechanical engineering at Purdue University, and then a master's in biomedical engineering, and went on to receive his medical degree from Wright State University. He has a specialty focus of neuroradiology and radiology and the brain, head, neck, spine imaging, all the things that we order. And then also has 16 medical licenses and has been in practice for 20 years. So I want to talk a little bit about that perspective on how MRI accessibility has changed over time, which I'm sure he's got some great experience with. And so we are going to hop right into it. So thank you guys for coming on to Brain Chat. Welcome.
Thank you for having me.
Awesome.
Thank you.
All right. So first, before we get started, I always like to ask my guests how you got involved in the neurosciences.
Well, I'll go first. So, I growing up didn't have many family members or friends affected from a neurological standpoint. So my interest purely started off of just academic interest. And I did not go to medical school thinking I was going to get into the neurosciences, but it really found me and I fell in love with it from the beginning. And it's been a really good choice for me because definitely no regrets. But it's also served me well as I've continued to grow into my career.
Yeah. All right. What about you, Dr. Macarthur?
Well, I'm Dr. Macarthur Drake, and I'll be honest. When I started, college level, I had absolutely no idea what radiology was or any aspects of medicine. I wanted to be a rocket designer. And I worked for NASA when I was in college, and that's what I wanted to do. And somewhere along the line, I became a radiologist. So it's a long, torturous path. I won't bore everyone with it, but suffice it to say that just my interest in physics and engineering led me to become interested in radiology. And basically, as we know, radiology uses various techniques that we've understood through physics to image the body and to look in the body without actually having to surgically go in. And so that's what initially got me interested in radiology in general. And then at that point, I had several areas of medicine I was interested in, but this one seemed to be the one that kind of liked the most. And then once I was in radiology, then I just slowly became more interested in the brain, which is the most complex organ, I believe, and it's the most understood or misunderstood or poorly understood, I should say, organ. So that's what I always felt that it was something that was going to be evolving. Our understanding of it was going to evolve, and so I wanted to be part of that.
Yeah, that is pretty cool, Dr. Drake, and I do apologize I got that backwards. But, that is also one of the reasons why I wanted to go into neuroscience, because I felt like it was a cutting edge of medicine, like that in my lifetime and in my career, there'd be a lot for us to discover because everything is not figured out down to the receptor. And, for those of you who don't know, neurologists spend a lot of time on the phone with our neuroradiologist. Sometimes we argue, sometimes we agree, sometimes we disagree, but we talk to each other quite a bit. So there's a lot of camaraderie between the two specialties, and we lean on each other quite a bit, in trying to make sure we're serving people to the best of our ability. So first, before we go into talking about MRI specifically and what those lesions and white spots mean on the brain, let's talk a little bit about what MS is. So Dr. Rosenthal, why don't you start us off by just kind of giving us a basic definition of multiple sclerosis?
Right. So multiple sclerosis is an autoimmune condition that affects the central nervous system. That's always important because you want to differentiate that from other parts of the nervous system or other autoimmune diseases, but it affects the central nervous system and it attacks the myelin. It attacks the myelin in different areas of the central nervous system. So that's anywhere along the optic nerves, brain, or spinal cord. And it does it at different times. And that's really that hallmark of MS, where you're having these inflammatory attacks to the myelin at different times and in different areas of the central nervous system.
Absolutely. And so how has our diagnostic criteria really changed over time? Because I think this is important. And we're going to get to MRI, which is a crucial part, actually a key in diagnosing MS. But, back in the day, we used to have to wait for 2 episodes to happen to you. And then it became 1 episode and then some changes on MRI over time. And now we're able to diagnose people in one sitting, right? If they have old and new spots on their MRI, now we can diagnose with MS and begin treatment earlier.
Exactly. And I think that's how the diagnostic criteria really have evolved. At the end of the day, we want to identify people who are at high risk for having MS and with the diagnosis, put them on treatment before they have additional attacks. And so as the MRI technique has advanced over time, I think our dependence on MRIs for making that earlier diagnosis has advanced. And that's where the criteria are now. They're very MRI heavy.
Yeah. So, Dr. Drake, now let's get into these MRIs. Now, I recall a time during my residency, which was, a little while ago. I've got a lot of gray hair that people can't see. But I recall a time, well, one before MRIs were available, but before MRIs were very difficult to obtain. So I recall as a resident trying to order an MRI on a patient, and they would call me back and be like, "Do you really need this? This is an expensive test, right?" And sometimes I'd be able to get it and sometimes I wouldn't. So tell us about kind of how MRI has really helped revolutionize our ability to diagnose multiple sclerosis, and maybe how increased availability has helped us to be able to diagnose these conditions earlier.
Thank you. So MRI, well, I'll step back for a second and say radiology, we kind of have 3 roles in the diagnosis of multiple sclerosis.
Mhm.
We number one, we act as a confirmatory, specialty. So if there's clinical suspicion of it, the MRI, in other words, neuroradiology or radiology, will evaluate the neural axis, and we can confirm it. The other role that we have for radiology in general for multiple sclerosis is to make sure that that it's not something else. And you kind of touched on that. There's a differential diagnosis. There are other possibilities of things that can cause lesions in the brain and in the spinal cord and in the optic nerves. So, and some of those may present clinically similar to multiple sclerosis. And so radiology's role also is to consider other things and see if there are other findings that can support maybe other diagnoses. And then, of course, MRI has a role in monitoring, long-term monitoring of, progression of multiple sclerosis or complications of multiple sclerosis. And so that's kind of what in general, what radiology, how we help in this area. And along the line of your question, MRI has everything from your cell phone to the computer that you're probably watching on, has evolved, and it's evolved very rapidly since the 1990s.
Mm-hmm.
Our techniques are, we have stronger or higher field magnets. We have a faster scan times. And also, there's been more investment of MRI, so it's more ubiquitous in the medical community now versus, say, in the year 2000. So it existed then, but there were fewer MRIs. Now there are many more, and MRI is actually becoming even more. They're talking about making portable MRIs and things coming along. So some of it is just technical engineering has improved the quality of MRI. We do know how to make, like I said, higher field magnets, which can give us better resolution. So that's how MRI has evolved, and that's what MRI's role is in multiple sclerosis.
Yeah, so I kind of like to explain it like it's not as simple as our cameras on our phones, but that the picture that you were able to take when you had that flip phone is a lot different than that 5G camera. And so our MRI techniques have also improved over time where we're able to see more. I remember when there's a certain type of image called a stir image that first became available for spine imaging, and we could see the lesions from MS a lot better on that type of image than we could before on the previous types of images. So let's take a step back and let's talk about what are other diagnoses, right? A lot of times we talk about MS as a diagnosis of exclusion, meaning the symptoms can be caused by other conditions, right? People commonly have symptoms like numbness and tingling, weakness. They may have visual changes, or sometimes people will have very vague symptoms like fatigue, and their MRIs may be abnormal, but maybe it doesn't look like MS. So what are some other causes of people having lesions or white spots on their MRI besides multiple sclerosis? We'll start with you, Dr. Rosenthal.
Yeah, and I always try to explain to patients when I see them that most people with lesions on their brain don't have MS because it's not terribly uncommon to have spots or white spots on the brain. And so when we look at MS and maybe put it under that umbrella of white matter disease, there are a lot of different things. And probably one of the most common ones are going to be like high blood pressure, high cholesterol, things that we consider to be vascular risk factors. Smoking, for example, people who have history of migraine oftentimes can have white spots too, history of head trauma. Some people are just born with white spots, and unless you had an MRI right out of the womb, you never know. And so that's where having MRIs over time is so important to be able to track changes. But, when we are looking at MS, and this obviously falls under radiology as well, we're looking for a very specific type of white spot. And we're looking at it in the context of those symptoms, because you really have to have, again, the white spots that have the correct appearance to go along with MS and the history of the symptoms to go along with it as well.
Right. So I love what you said, Dr. Drake, about the radiology or the MRIs being confirmatory, meaning we have some type of suspicion. Maybe someone comes into the neurologist with certain symptoms, or they may go see other doctors. Some people go to their primary care physician first, or they may see an ophthalmologist first for certain symptoms. And then we refer them for an MRI, and that leads to diagnosis. So what are you looking for when you're looking at those white spots to determine if it looks like MS versus some other condition?
The first thing I look for is the history. The very first thing I look at the indication. I look at what the neurologist wrote. That's the first thing I look at before I even look at the study. The next things I look at are the patient's age. That's important. Multiple sclerosis can affect any age, including children, but it peaks at around age 30 in females. So if we're looking at someone who's 75 and I see abnormality matter, these lesions, I'm going to think a lot differently than if I see someone 30, even if they had the exact same number of lesions. The age difference makes a big difference in what I would be considering. To kind of talk about some of the other things that can give abnormality. And so when you say spots, I just want to maybe show an image or just kind of give an idea to the audience of what we mean by spots and what we mean by white.
You got it.
So for radiologists, when we're looking at the study, first of all, it's going to be their sequence MRI, and you see these white areas, these bright areas that are being pointed to. These are what many terms, we have a lot of terms for these: plaques, spots. Radiologists, we call them lesions, T2 and flare signal hyperintense foci. That's what I describe it as. So that's what they are, and I just wanted the audience to see them clearly so that we know what we're talking about. So to answer what type of things I'll look at on MRI, there are a couple of criterion that would make me raise the possibility of multiple sclerosis. There's location. Okay, so if I see a certain type of lesion, like we saw, located in the periventricular space, that's a concern.
So the periventricular, meaning right next to the fluid-filled spaces in the brain, those big holes in the middle, so to speak. Everybody's got a hole in the middle of their head. So right next to those fluid-filled spaces. Yeah,
next to those fluid-filled spaces, that starts to raise the possibility. There's basically 4 places in the brain, and this is what we radiologists call dissemination in space, meaning that lesions need to be disseminated in multiple areas. That raises the possibility. MS, first of all, I should back up and say MS can look like anything. Okay, honestly, or it can affect any part of the neural axis: brain, optic nerves, meninges, spinal cord. But if they're in certain locations, and that's what we use the term disseminated in space, then it starts to raise the possibility. There's nothing that I'm going to see on the MRI I'm going to look at and say that's MS. There's nothing else it could be. That's MS. Okay. The way you think about it is when you see abnormalities, you start to raise your suspicion of certain things and lower your suspicion of other things. It's a sort of a game, you're playing odds. And so based on what I'm looking at, I start to raise the possibility of MS. So I want to step back and say that, and then continuing on. So there's really 4 locations we look for: the periventricular, which is next to the ventricle, which is the fluid-filled parts of your brain. So if we see lesions there, we start to worry about them, that being multiple sclerosis. Subcortical, which is near the gray-white matter junction. If we see lesions in that region, we start to think about multiple sclerosis. If we see it in the infratemporal region, which is the brainstem, the medulla, the pons, and the midbrain, and also the cerebellum. If we see lesions there, then that also raises the possibility. And then the last out of the 4 places is the spinal cord. Most commonly affects the cervical spinal cord. So those are 4 locations. And if I see lesions in 2 out of 4 of those locations, then I'm really starting to think about multiple sclerosis. It gives me evidence. It points me towards that direction. I raise that as a possibility. I'm never going to say in a report, this is multiple sclerosis. So that's a typical way in which a multiple sclerosis, thought process behind it. So that's, go ahead.
Yeah, so we're looking for spots or lesions, white matter changes. People kind of call them a variety of things, but we're looking for those lesions in certain areas that will lead us to, I look at it like building a case for or against MS. So we look at the clinical symptoms, we look at the MRIs, and then, we look at the history, their physical exams. All these things are kind of building a case for or against MS. So when we look at these lesions, right, a lot of people ask the question, how can I know how long they've been there? Oftentimes someone will come to diagnosis, and let's say they had their very first symptom. Because MRIs are more available, we're able to catch people sometimes after that very first symptom, but they may have multiple spots in different parts of their brain that have accumulated over time. Is there a way we can tell old from new spots, so to speak? And so this is a common question that I want to pose to both of
Yes,
you,
that's
that
actually
our
the next
patients
thing.
often ask us.
Yeah, that's a great question. That's the next. I was actually going to address that next.
Okay, awesome.
So I mentioned the locations. Okay, so the next concept for MRI is what we call dissemination in time. So what that means is if I'm seeing lesions that are different phases. Okay, so if I'm looking at a brain or spine and I've seen multiple lesions and they all look like they're of about the same time, that makes me think a little less likely that it's multiple sclerosis.
Mm-hmm.
Maybe I should phrase it this way. It doesn't raise my thoughts about multiple sclerosis as much as if I see lesions of various ages. If I see lesions of various ages, old and new, that's called dissemination in time,
Mm-hmm.
then that really raises my suspicion. So to answer your question specifically, the image you showed, just looking at that image, it's hard to say just off of one image, but those lesions look roughly the same age, I'll say.
Mm-hmm.
To look at lesions, to see older lesions, they can look, they can be what I call them burnout MS, in which the multiple sclerosis has been there so long that it basically produces, it just basically is parenchymal loss, meaning that there's a small focus of which there's no more brain left, it's just fluid. So basically it started off as a lesion, a white spot, and then it's just totally involuted and there's nothing but just a tiny focus of fluid in that region. That would be an old MS lesion. So if I see an old lesion and a new lesion, then that really, even if the patient's asymptomatic, if I see that, it could be routine. They come in they have headaches or for whatever reason. If I see that, I'm going to at least raise that as a possibility because I'm seeing lesions of different age.
Mm-hmm.
So if I see lesions of different age and I see them in different locations, then I really start to think about MS. And then the final thing to think about is if I see a lesion that enhances and one that doesn't enhance.
Yep, I'm going to show a picture there.
Okay, great. So what we're seeing here is the bottom two images are axial post-contrast T1 weight images. And we're seeing a rounded, bright circle, kind of a concentric circle. Here's a little bit more focal abnormality. So we see multiple abnormalities. These are areas of enhancement. And what that means is that the patient has received intravenous contrast and that these lesions are lighting up, okay, for lack of a better way of putting it. These lesions enhance. And the fact that I'm seeing multiple lesions like this that are enhancing, I would like to see some that don't enhance though. If they all enhance, then like was what I was saying, if they all look the same, then it doesn't give you as strong of a case for multiple sclerosis as if you see one different phases. In other words, one enhances and one doesn't. So what does enhancement mean? Enhancement means it's a disruption of the blood-brain barrier and that the contrast that's injected into you crosses the blood-brain barrier and then lights up on the MRI. And so that's evidence of an active multiple sclerosis plaque. Okay.
So an active lesion is one that lights up with contrast.
Yes, and they can be active for, if you have a new lesion, they can enhance up to 6 months, honestly. But typically it's 2 to 8 weeks of enhancement. And then typically they don't enhance after that. This is if we're dealing with MS. Right. Now, mind you, there are other things that can look like that picture you just showed me. So we're assuming that that's MS. And once we're confirmed that that's MS and we're following these patients, that's how we have to think about it. So, yeah, and then I can talk a little about what other things can cause abnormality in the white matter. I can talk a little bit about that too.
Yeah. Yeah. So so that was great, and I've been trying to pull up, a couple pictures to add to give a visual, because sometimes it's a little difficult to conceptualize if you're not actually looking at some type of picture. But, one of the things I think is very important, we talk a lot on this show about empowering people. And one of those things that's really important is, we don't expect everybody to be a neuroradiologist or a neurologist, but I do consistently review MRIs with my patients, and I want them to at least kind of have a broad idea of what we're looking at, in terms of, this is related to your MS. These are new lesions versus older ones. And what does this mean in terms of, do we feel like your medication is working or not working? So I'm going to pause here and go to Dr. Rosenthal. So when we're looking at these MRIs, what are we really trying to understand in terms of if we feel like a treatment plan is working for someone living with MS or not?
Right. And so as it stands now, there are, when we're getting those MRIs, just like was mentioned, it's important, I think, as a patient to know the right questions to ask. And what we're looking for is your doctor in terms of, is this medicine working? And so probably the most common one is new lesions. Are there new lesions compared to my last MRI? And that's something to certainly ask about, especially in comparison. If you've been on a medicine for a long time and that MRI that you're comparing it to from before, you want it to look similar. You don't want to see new lesions. When we get that contrast, we really are trying to also exclude active disease, these new lesions. That's really important, especially if you're not on treatment or if you've just started a treatment, to make sure we've accomplished that goal of stopping active lesions. And so those are always two questions I think are important to ask when you get an MRI. Is there anything active, and is there anything new? We know that those old lesions aren't going to necessarily disappear. They may change a little in appearance over time, but they're all that scar from that inflammation that was there in the past that lasted 2 to 8 weeks or so is always going to be there. And so that's important. But I think it's also important, just as MRI technology is advancing and that sort of thing, to maybe ask other questions, maybe a little harder to measure, but you're looking at brain volume, for example. We at our MS treatments now are pretty good at stopping new lesions and stopping active disease, but as a lot of MS patients know, sometimes there can still be symptoms despite that, changing symptoms. And so with our MRIs, of course, we're always looking for new and different ways to try to measure that and see if there are any correlations. And so, those are things that will continue to develop over time. But looking at the brain volume is another question that I think is appropriate to ask if there have been changes over time with that as well.
Yeah, absolutely. So again, when we do tests, we do them for a reason. And as Dr. Drake discussed earlier, a couple of one of the important uses of MRI in MS diagnosis is to help with monitoring over time. So we're trying to determine if we feel like what we're doing is working, so to speak, or if it's not working and we need to change course, or we need to switch gears or what have you. And so when we talk about MRIs, another common question that I have a lot of people living with MS ask is, how often should I be getting MRIs? We used to say once a year. It varies very widely from practice to practice. And then I think another big question that's come along in the past couple of years is that people are concerned about contrast. Now, traditionally, we think about contrast medicine that people get with CAT scans that can affect the kidneys, and we have to get kidney tests before we do that. But traditionally, we didn't think of MRI contrast as very harmful, so to speak. But there have been concerns about it hanging around in the brain for longer periods of time. So let's talk a little bit about how often people should get MRIs, and then what does that contrast mean? Is that contrast harmful?
Okay, so I would say, as we all know, any medicine has side effects, or any therapeutic agent has side effects. Honestly, if we could live in a world where we didn't have to take anything, that would be ideal. But we don't live in an ideal world, so let's start with that.
Exactly.
So as we all know, there's risks, benefits. So the question is, does giving contrast is it more beneficial than the risk? That's the way we should think about all of this. So and yes, there are recent reports and there's recent studies showing that contrast can linger around in some patients. Most of it is in bone. A little bit is in the brain. That as far as everything that we understand at this point, it does not have any long-term effects that we understand. But it is something that's factual and it needs to be discussed and thought about. But again, if you are unfortunately suffering from multiple sclerosis, the benefit can greatly outweigh the risks. If you need evaluation of your lesions to see if they are progressing or are there new lesions and things along those lines. There is a role for MRI out contrast. And so sometimes, if there's other reasons why you can't get contrast, then, we may go without contrast. So that's the way I would think about the issue of contrast and the risks. There are risks also with nephrogenic systemic sclerosis. Also, you can have, skin and renal manifestations of contrast. And of course, like any other medicine, you can have an allergic reaction to contrast.
Right.
It's not very common, but you can have a true allergic reaction, which can be, life-threatening at the worst. But again, these incidents are very, 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 very unlikely, but it's not impossible. Lesser reactions include just headache, nausea, and also just going in the MRI itself. Some people are claustrophobic and things. So there's some aspects of it there that also affects patients, how they feel about these things.
Absolutely. And I think the interesting thing, I paused for a minute to talk about claustrophobia. It's been very interesting. Now, there are some patients, now if they get a brain MRI, oftentimes there's something put on their face, which can definitely make people claustrophobic. But I found it very interesting that some people have been getting MRIs for years, and they'll get 80 MRIs. And for some reason with 81, all of a sudden, they're like, oh my God, I can't do it anymore. Which it's just kind of out of the blue, that sometimes people will just develop claustrophobia, I guess, over time, the more they're getting those scans. But how often should people be getting MRIs, Dr. Rosenthal?
So there's
Go ahead, Dr. Drake. You were going to say something.
I'll be brief. I would say that, if you have an initial clinical presentation, then you can follow it up in 1 to 3 months. And if it doesn't change, you can go up to 6 months like that. And then at that point, you can go 6 to 12 months.
Yeah, absolutely. So that often is my practice, right? If we're concerned, right, and we're not diagnosing, because sometimes there are people who have symptoms that may or may not be related, MRIs that look typical. Also, now we're talking a lot about radiologically or radiographically isolated syndrome. So those are the people who get an MRI for a car accident or a headache, and it looks like classic MS, but they've not had a clinical syndrome, that is typical of MS. And so we often follow these patients very closely and use that imaging to determine if we start treatment or when we start treatment. Any thoughts about that, Dr. Rosenthal?
Yeah, when I explain the spectrum of MS to patients, it can be anywhere from barely MS and we're scratching our heads 10 years later to wonder if it was ever there because it's been so mild, to really aggressive MS. And I really feel like radiographically isolated syndrome is on that spectrum. And we know from MRI studies as well, if you look at some of the family members of people with MS, sometimes they can have lesions that look like MS, but they have not and never will develop symptoms and therefore don't have that diagnosis. And so it is something that sometimes causes a little bit of a conundrum for us because we don't necessarily know where to go in terms of treatment. I do think a majority of people, when you are not just seeing those lesions, but seeing them evolve over time, it does kind of lend you more towards being a little bit more proactive in those patients. But it's certainly something I think we're still learning a lot about.
Yeah, absolutely. And I have some patients who are very hesitant, when we talk, sometimes they will have had a syndrome, maybe something vague, and they're just very hesitant. They're like, I just want to let's keep monitoring and, let's see how it goes. But definitely radiologically or radiographically isolated syndrome is something that is becoming more and more common as people are having increased accessibility to MRIs. And let's go back and let's talk about some of those other things that can cause lesions that look similar to MS.
Yeah.
Dr. Drake, you were going to mention some of those. Certainly, things that come top of mind are syndromes that are very similar to MS, such as neuromyelitis optica, which is a demyelinating disease that involves often the optic nerves and the spinal cord. Also, there's anti-MOG antibody disease, which is very similar to neuromyelitis optica. In children, we sometimes see something called ADEM, which can have very, very dramatic changes on MRI, but usually happens one time and often they fully recover. But there are also some other conditions that we look for, other autoimmune conditions. What are some of those things that may mimic MS?
So, in general, the differential diagnosis or other things that can simulate multiple sclerosis includes post-infectious process. So, if someone has exposure to Lyme disease, that certainly can give you abnormalities that look like MS. Vasculitis, so there are multiple vasculitides that can look like multiple sclerosis. Um, and then lupus is another one that can mimic multiple sclerosis. It can give you white matter lesions. So those are the things that I kind of would think about. There's some other things, and the term, I'll just say quickly that the term demyelination, or I should say white matter diseases, technically we still use that term, but we do know that multiple sclerosis can affect all aspects of the brain, including the gray matter too. So it's actually, that term is starting to get out of favor at some point. But there's some other things that can give you white matter disease, such as PRES, posterior reversible syndrome, encephalopathy, that can give you posterior abnormalities in the white matter that can be associated with hypertension, pregnancy, and then that's also reversible. So a lot of these that I just mentioned, the key is that you'll have them on one study, but then you'll do a follow-up study and they're gone. Even the disease you mentioned, ADEM, that typically occurs in children, after an infection or post vaccinations. You can see it. It's a well-established thing that we've known about for decades, and it can look exactly like MS. But the key is that all the lesions will be of the same age, and so when you do a follow-up, they won't be there anymore, and there won't be any change. There won't be any new lesions, and so that's what makes us, consider ADEM.
Absolutely. Anything you want to add to that, Dr. Rosenthal?
Yeah, I mean, there's just so many things under that umbrella. And I think MS gets a lot of attention because it's one of maybe the more common ones for demyelinating disease. But there are a lot of things that we consider when we're seeing a new patient. I'll add, sarcoidosis and a lot of the different, there's so many different autoimmune diseases that, in addition to affecting the whole body, can affect the brain as well. But with that patient history, that interview, and doing the tests that we do, we really are able to, and in getting those MRIs over time, to narrow down and find that diagnosis. When we apply the diagnostic criteria for MS, it is important that we apply it to the correct patients, because again, it's not, there unfortunately is not just one test we can do to make that MS diagnosis. It really is a combination of the history, the exam, the MRI findings. If there was a lumbar puncture, what does that show? And we really put it together. And sometimes there is a different explanation. And sometimes that different explanation isn't apparent right from the outset. It may be apparent later. But it's just important to know that, the differential exists and to be followed over time.
Absolutely. And I see a question in the chat that's asking, what are the signs of MS? So we talked a lot about imaging. We talked a lot about MRI, things that we would rule out. But some of the common symptoms of MS could be things like numbness or tingling, either in, let's say, an arm, a leg, on one side of the body. Sometimes it can be from the waist down. People can also have visual changes. They may have loss of vision or decreased color vision, a problem called optic neuritis. They can also have weakness, difficulty walking. Sometimes people have a foot drop or a foot drag. MS can very often be mistaken as symptoms of a stroke. So some people will go to the hospital and they will call a code stroke or an emergent workup for stroke and actually find that they have MS. And so these are some of the common symptoms that people present with. But again, we have to make sure that we rule out other conditions that could reasonably cause these symptoms, such as the things that have been mentioned. Also, we look for things like vitamin deficiencies, vitamin B12, other things like that that can be mistakenly diagnosed as multiple sclerosis. And there's been a lot of research recently about misdiagnosis. So, in our excitement about getting MRIs, in some cases, people have seen spots and started people on medicine and later realized that it was not multiple sclerosis. So we certainly do have to be careful with giving people the diagnosis when we're putting them on medications that can affect their immune system. So we're getting kind of close to the end. This has been a great, very informative conversation. But two things I want to talk about before we finish up today. One of them I want to talk about is what we call kind of the clinical MRI paradox, meaning a lot of people, once they have developed MS, maybe had it for a while, will come in and say, "Hey, Dr. Rosenthal, hey, Dr. Williams, I feel like I'm getting worse, but every time you get my MRIs every year, you tell me they look the same." What is behind that, or what is causing that? And then the second thing I want to talk about is just a little bit about some of the newer techniques that may be coming down the line to help us to understand a little bit more about what's going on underneath the surface, aside from what we can see on our traditional MRIs.
So, MS behaves differently in everybody. And when you look at it, though, for most people, that natural history of MS, there's a lot of active disease and new lesions early on. As time goes on, most people are less likely to keep accruing new lesions and have as many relapses, whereby they're having new symptoms that they've never had before. And we do kind of see that there may be some progression of symptoms outside of the MRI changes, and a lot of people sometimes refer to that as secondary progressive MS. Fortunately, with all of the disease-modifying treatments we have now, that natural history has changed a bit, where if you look at some of the older studies, they'll say that risk of progressing to secondary progressive MS within 10 to 20 years was like 80%. And now it's thought maybe more closer to 15 to 30%, because we're able to really do a lot better at shutting down the new lesion formation early on. And so I definitely can say there are improvements in that natural history, but a lot of people over time are having worsened symptoms, and that MRI is staying stable. And that just highlights some of the things that we are kind of missing still in our standard MRIs, because there are changes that are happening in the brain that aren't necessarily represented by a new area of active inflammation or a new lesion. And so that's where some of the MRI technique, I believe, is advancing or trying to advance. And we're looking at other biomarkers to try to identify, what's going on and what's happening. And the other thing I'll just bring up briefly that we need to consider too is our aging population, because looking at how the normal nervous system changes that go along with aging kind of are impacting people who have lesion burden from MS that may have been there for 20, 40, 50, 60 years.
Absolutely. Anything you want to add to that, Dr. Drake?
Well, like I mentioned earlier, multiple sclerosis now we know affects, neurons, axons, the gray matter, the white matter. So we know now that, with better histology and pathology, we know it affects all aspects of the brain. So you could have worsening symptoms, and yet it could look relatively stable on MRI. That doesn't seem to be out too far off, far-fetched. But that's for conventional MRI. There are some new techniques coming along, like diffusion tensor imaging and magnetic resonance spectroscopy. Some new techniques that we're evaluating that are not they're in an academic setting mostly. And if you happen to be near an academic center like a university, you may be able to participate in getting in that type of study. That's something you certainly should talk to your neurologist about if you are interested in that. But it's not widespread yet, and it's not all of the findings and things have not all been mapped out. We're still doing research in it, but it's certainly something that's well established and well known. And so those are some alternative things that can better evaluate the progression of MS.
Awesome. Well, this has been a very, very informative brain chat. I'm very excited. We got to talk about MRIs and really explain them to our patients. I know a lot of people in between those visits that pop those discs in their computers and they're like, I don't know what I'm looking at, but hopefully this will give them a little bit more guidance when they're with their doctor to ask questions about, old and new lesions, and maybe just a little bit more information to go into that office visit informed and prepared to ask questions. So if you had something you wanted to leave with our brain chat audience today, what is kind of one piece of advice that you would leave with them? We'll start with Dr. Rosenthal.
I would say after this talk, if you haven't already reviewed your MRIs with your neurologist, that's something I would definitely put on the agenda for your visit. I think it's important for all MS patients to know what their brain looks like and to understand what those changes are.
Anything you would say, Dr. Drake?
I think I would ditto what she just said. That conversation with the doctor, the neurologist is most important with the patient. And although you don't see radiologists, patients don't see radiologists, I, for one, would be open to talking with the neurologist, with the patient too, if the circumstances presented itself. That's
Awesome.
also a possibility to keep in mind. Another thing I would always say is listen to your body. You know your body better than even the clinicians, the radiologists, the neurologists. Listen to your body. Don't ignore things. But you also, you don't want to be too overly worried, but you do want to listen to your body very carefully and in all aspects of medicine, not just multiple sclerosis.
I love it. I love it. I love it. And the only other advice I would say is just be careful about interpreting your own MRI reports. So I very commonly will get frantic calls, I read my MRI report and it said this, this, and this. Just make sure that you also review those with your healthcare team. If you have any questions about it, review it with them. Because sometimes people will get scared or nervous when they read it, and it's not, as big of an issue as they may think it is before they review it with their doctor. So with that being said, we would like to thank our sponsor, Biogen IDEC, for sponsoring Brain Chat. And we're excited to kick off this season 3. I also want to thank Dr. Rosenthal and Dr. Drake for hanging out with me today and helping everyone understand that MS diagnosis and understand their MRIs. Thank you to all of our Brain Chat fans. And we will see you again in 2 weeks.
Thank you.
Thank you.